Acute respiratory failure is not a primary diagnosis. Based on the definition, it's a condition wherein you're hypoxemic and your ABG shows a PaO2 of less than 60, PaCO2 greater than 50, and your pH is less than 7.35. In other textbooks, the third condition is a oxygen saturation of less than 90%. Again, respiratory failure is not a primary condition. It is a primary diagnosis. It's a condition. You meet the condition based on the following. If your ABG shows a PaO2 of less than 60, a PaCO2 of over 50, and your pH is less than 7.35, or your oxygen saturation is less than 90, then you are in a respiratory failure state. Yes.
In the textbook, it says 2 less than 60. So does it mean like up to 60 or less and less than, or it's just less than?
Less than 60.
Okay.
When did you say a PaCO2 greater than 50?
Yeah, meaning if your PaCO2 is over 50, then that's respiratory acidosis, right? Okay. Any question on the definition? So that's why the reason why it's not a primary condition is, can this exist alone? No, never. So there has to be a primary diagnosis, and then you went into acute respiratory failure. So let's say, so who are at risk for acute respiratory failure? So let's look at the list of causes. So the examples given here are, let's say, COPD patients. They go into respiratory failure a lot. So they can be, in the case of COPD, this is unique because they can have acute or they can also have chronic respiratory failure. A patient with pneumonia can go into respiratory failure. So most of them, I'm not saying 100% respiratory problems, because there can be non-pulmonary causes of respiratory failure. For instance, can you think of any condition that could also do this that's not a lung problem? Can a septic patient go into this condition as well?
Oh, yeah.
Yes. Okay. So this is what I mean by it's not 100% pulmonary causes. It can be non-pulmonary causes as well. Let's say a burn patient, can they go into respiratory failure?
Yes.
Yes. So that's not a respiratory condition at all, right? So it doesn't have to be a pulmonary cause that can lead to respiratory failure. Let's say obesity. I am, let's say, 560 pounds and I'm only 5'4". Can I go into respiratory failure?
Yeah.
Yes.
Yes.
So meaning it can be, there's two types of respiratory failure. It can be an oxygenation failure, right here, oxygenation failure, or it can be a ventilatory failure. So most ventilatory failure types of acute respiratory failure can be non-cardiac. For instance, look at these here. So in ventilatory failure, the problem is with the rate and depth of the ventilation. What is ventilation? The act of inhaling and exhaling, correct? So can you relate them to, let's say, someone who overdoses on cocaine, let's say, or opioids or heroin, right? Can they go into respiratory depression?
Yes.
What about patients with head trauma? Sepsis, you agreed with me? Hemorrhage, sleep apnea, or let's say myasthenia gravis, Guillain-Barré syndrome, because they affect the diaphragm, right? Or ALS. So are these pulmonary in nature?
No.
None of them are, but they are something that affects the diaphragm at some point, correct? So therefore, that can lead to respiratory failure as well. So again, there's two types, either a failure of ventilation or an oxygenation failure. Or if it's oxygenation failure, then that would be the respiratory examples we gave: COPD, COVID, pneumonia, asthma, cystic fibrosis. Okay, so any lung condition can go into oxygenation failure. Any questions so far? Regardless of the cause, though, whether it's respiratory oxygenation type or ventilatory type failure, what do you think is the diagnostic basis? How do we know they are in respiratory failure? ABG. Okay, the only definition here is based on ABG. So when we have these patients here, they're admitted in your unit for these conditions or for these conditions here, you draw ABGs and their ABGs show a PaO2 of less than 60, PaCO2 of greater than 50, and a pH less than 7.35, and their oxygen saturation is less than 90. What do you think is the diagnosis? Whatever the condition is, so let's say Guillain-Barré syndrome with respiratory failure now. Got it? Because there will never be a primary, meaning you come in, that's your primary diagnosis. It can't be. You came in with something else and then we added the respiratory failure. So therefore, is this a primary condition or a primary diagnosis or a state? It's a state, it's a condition that you are in respiratory failure now. So what do you think is the treatment? Only respiratory failure, okay? We of course, we have to treat the underlying cause. So if the patient's here for myasthenia gravis, Guillain-Barré syndrome, they continue treatment for those. Or let's say here they are in ARDS, heart failure, COPD, PE. We treat those. However, what do we do about the respiratory failure condition? How do you treat it? Yes, Ulu? Oxygen. So we won't have time, and it's not on your exam 3 for intubation and mechanical ventilation. So we'll do that next week after the exam. But that's basically the treatment. We give them oxygen. So you keep them alive with oxygen, however you deliver that, nasal cannula, mask, or a BiPAP, CPAP, or a mechanical ventilator, whatever is necessary to keep their oxygenation back to normal. No, that's not on your blueprint. Here, it's only up until chest trauma. So we'll end with chest trauma today. So airway management and mechanical ventilation will be next week because you can't do mechanical ventilation without an airway, meaning without an artificial airway. Yes, Soda? You had your hand? Oh, no. Was it usually? Manifestations, there's nothing specific about respiratory failure. What do you think the patient will look like if their PaO2 is less than 60? CO2 is over 50. Exactly. So here are your manifestations. So are these exclusively seen in respiratory failure? No, it could be any hypoxic patient, any asthma, acute asthma patient, COPD patient, they have these manifestations, right? But how do we know that it's not just asthma or COPD? ABG. So you draw ABG and what happens to your PaO2 again? And CO2 will be over 50. pH will be? Okay, 7.34 or less. All right, very good, children. And like I said, oxygen. So if we need to intubate the patient, then they will be intubated and mechanically ventilated. That's it. We'll stop it right there. Keep it simple because we'll do the airway management and mechanical ventilation separately. And we'll discuss your nursing responsibilities about these again next week. Questions? All right, so I'll come back to this next week. Let's go to ARDS. What is ARDS? Very good. So what is it? Okay, so yes, kind of, sort of. Like acute respiratory failure, This one is not a primary diagnosis either. It will not occur on its own. ARDS is more of a symptom of another condition. You remember DIC? Did DIC occur on its own? Never. What were the conditions that led to DIC? Sepsis, what else? Trauma, right? Hemorrhage, okay, cancer. Okay, so were all those we mentioned, are they minor conditions? Are they minor? Like
No.
sepsis, yeah, it's just sepsis. Okay, these are all life-threatening conditions, right? And then the patient developed DIC. So if ARDS is the same, meaning this only occurs when the patient sustains specific life-threatening conditions, so is ARDS different from DIC? The same self-destructive mechanism. So if you're saying DIC is a self-destructive response by the body to something life-threatening, so is ARDS. In fact, ARDS can occur together with DIC. So let's look at what happens in ARDS. So the name, the main problem in ARDS is acute lung injury. Now, although this term says lung in it, just like acute respiratory failure, there can be non-lung causes of acute lung injury. You follow? So it doesn't have to be a respiratory condition, meaning you don't have to have COVID, pneumonia, COPD, PE, or sarcoidosis, or let's say your lungs are filled with mud, for instance. It doesn't have to be like that. There can be non-pulmonary causes that can still lead to the same acute lung injury. So let's explore those shortly. So let's look at the mechanism first. So how do you get into acute respiratory distress syndrome? So technically, this is a form of respiratory failure as well. So therefore, since it's also a respiratory failure, what will the ABG show? Which are PaO2 less than 60, greater than 50, and okay, same thing, same. However, what is in addition to that now are the following. So there is diffuse alveolar damage. What are the alveoli again? Okay, so we have how many of them in our body? We have 100 million of them. Okay, so each of them, because it says here diffuse, so diffuse alveolar damage that results in sudden progressive pulmonary edema, increasing infiltrates on X-ray, now fluid in your lungs, hypoxemia, because can gas exchange occur when your lungs are wet? So you understand hypoxemia, correct? Here, unresponsive to oxygen, because unlike acute respiratory failure, did the patient with acute respiratory failure respond to oxygen therapy? Yes, they improved, because are their lungs wet? No, there was no such thing. This was not mentioned under respiratory failure. The problem here is because the lungs are wet, can you have gas exchange possible? That's why it says here, unresponsive to oxygen supplementation, regardless of the amount of PEEP. I'll discuss PEEP next week. And the absence of an elevated left atrial pressure, meaning there's pulmonary edema here, correct? You see this pulmonary edema? All right, so let's remember pulmonary edema that occurred in heart failure. Was there pulmonary edema in heart failure? What caused it? Why did the acute heart failure patient have fluid in their lungs? How did they get that pulmonary edema? What was the exact mechanism? Congestion, correct? Okay, so the sheer congestion in the heart chambers congested the pulmonary vein, congested the pulmonary artery, correct? And then they leak. Of course, water will leak out of any congested blood vessel. Here, is it happening here? Is this patient having heart failure? Not at all. No, there was no heart failure here. The problem here is this one here, the alveolar damage, because once this alveolar damage occurs, the patient's capillaries around those alveoli become very leaky. So they start leaking fluid. And of course, if this is your alveolus, here again, this mouse is one of 100 million alveoli. It's wrapped with capillaries, correct? For gas exchange. So if those capillaries around it are leaking and they leak fluid, where will that fluid go? Inside the alveoli. So every one of those 100 million alveoli are now wet. They're filled with water. Now, how can gas exchange occur there? Impossible. Impossible without mechanical ventilation. So you have to force that water, that air in, push that water out of the alveoli, and then make gas exchange possible. But as soon as the ventilator stops giving the breath, where will that water go? Right back into the alveoli. But at least for a moment, we make gas exchange possible. Okay, so that's the only way. That's the only treatment for ARDS is mechanical ventilation. But of course, we still, just like acute respiratory failure, we still treat the underlying conditions that led to the ARDS. Clear? Okay, so let's look at the most common causes. So what causes acute lung injury? Let's start here. A wide range of factors are associated with ARDS. We actually have a chart. We'll get to that shortly. So what can lead to acute lung injury? Let's start with direct injury to the lungs. Let's say you inhaled smoke or fire. Can that cause injury? Direct or indirect? Direct injury. You inhaled hot fumes. So what do your lungs look like now? Very swollen, very watery, right? You burned your lung tissue. Or it can be indirect. So the indirect lung injury are now the causes that are non-pulmonary. So that includes sepsis, okay? That includes pancreatitis, osteomyelitis, etc. So here are your risk factors, chart 1920. So what can lead to acute lung injury and then therefore lead to ARDS? Aspiration. Try breathing in your gastric secretions. Let's say Tyree is dead drunk. He's passed out on the sidewalk, supine. He started vomiting. Vomit came up, and then went back in. So he aspirated it. In that emesis there's tequila in there. There's some tacos. Okay. There's some chicken wings. Of course, with all the gastric juices. Okay, so there's some gastrin, pepsin in there, hydrochloric acid. Okay, so pour all of those into his lungs. What will those lung tissue look like now? I'll leave you to your imagination. Okay, so is that direct lung injury?
Yes.
All right, Sanda, we can go over here, do the same thing, COVID pneumonia, drug ingestion in overdose, fat embolism, etc. Again, so if you look at these, they're not all pulmonary, are they? No, but then one way or another, they lead to sepsis, correct? Okay, and then that's where your lung injury occurs, either directly or indirectly. But the same thing is going to be the end result. So any of these conditions here, what do they do to the capillary membrane permeability? They increase it. So they cause your capillaries to become very leaky. And then when they start leaking, of course, you know the consequence on the lung tissue, okay, on the alveoli. So all those 100 million alveoli, all those capillaries become leaky, then they fill the alveoli with water. That's pulmonary edema. So therefore, going back here on the diagnostic finding right here. So why is there no elevated left atrial pressure in ARDS, while in the cardiac, in the heart failure pulmonary edema, there is, right? There's elevated right atrial pressure, right? Elevated central venous pressure, elevated left atrial pressure. Everything, all heart chambers were elevated because there was congestion, correct, Terry? So here, is there congestion in the heart here?
No.
No. What caused again the pulmonary edema?
Leaking.
The leaking of the capillary injury, secondary to acute lung injury. So the leaking of the capillaries resulted from the direct or indirect lung injury. Is this a good select all or apply?
Yeah.
Very good, children.
Actually, no, because you can find a little too much. So,
Which one?
Well, I'm not asking. I'm telling you, chart 1920. Here's another one. This is fairly new. About e-cigarettes. Anyone vaping here? Who's looking at who?
I am aggressive without betting without.
You just watch when you get home.
wait, can I ask, like, because you asked that, can I ask a question though? Is it the it's the nicotine that causes the problem, not the smoke, right?
It's the smoke. It's the
It's the
smoke.
smoke?
Oh, the smoke contains it. Remember when I explained COPD, emphysema last semester about the, remember protease?
Yeah.
Probably not, because you drew a blank.
No.
Yeah, so protease are the substances that break down debris, right? So let's say smoke, nicotine, whatever you put into your lungs. So the protease is there to break it down, to destroy it literally. Then because you can't smoke 24 hours a day, what will they do when you're not smoking? They're still there. They'll break down lung tissue. They'll break down bronchial tissue. So yes, that's your answer. I'm not testing the severity of ARDS. ARDS for me is ARDS. So we take it seriously. These patients are high risk for death. Okay, they have high mortality. What year is it now? 2023. Let me just give you a perspective. ARDS, because this started being discovered after World War II, the mortality then was 50%. You know what the mortality is now? 42%. World War II, 1950s to what is it year now? 2023. How come the mortality only dropped by 8%? So what does that tell you about ARDS? This is impossible to treat. Okay, very hard to treat. So it still has a pretty high mortality, 42% in the 21st century. So these are the consequences. Patients' lungs are very stiff, so therefore, can they breathe independently? You have to put them on a ventilator. They cannot achieve gas exchange without a mechanical ventilator. The lungs are very stiff, very non-compliant, impossible to ventilate without a machine. Medical management, it's really oxygen therapy. However you meet that, usually again, 9 out of 10 will be intubated and mechanically ventilated. We'll talk about PEEP again, like I said, next week. Now, the other therapy here, besides oxygen and mechanical ventilation, are the following. Not much. We can give them sedatives, muscle paralyzers, because do we want them exerting effort with breathing? No, they'll be using too much energy. They're wasting the oxygen. So we sedate them, paralyze them, let the ventilator do the work. And because any unconscious patient, we assume there's pain, so we give them opioids. It'll be infusion. They'll have a morphine or fentanyl infusion. And nutrition, of course, they're NPL, correct? Because they have an airway. So give them either NG tube feeding. We already discussed enteral feeding last week. So we do PEG tubes or nasogastric feeding. Look at the amount of nutrition they have. Is this normal or extra high? 35 to 45 kilocalories per kg per day. Oh, let's look at the number. So let's say I weigh 75 kilograms times, let's say 45. How many calories is that? So therefore, what can you say about their metabolic requirements? The sicker the patient, the higher the metabolic requirements. Keep that in mind. All right. So they require more than a regular person. All right. Because what happens to cortisol again during these episodes? Okay. So they require a lot of nutrition, high calories. This can reach, depending again on the weight. So let's say you have 100 kilogram, that's easily 5,000 kilocalories, right? That's equivalent to someone training for professional boxing, right? That's how much they burn, okay, when they're training for a major event. Or look at LeBron James. You can you imagine how much those guys eat?
Wow.
Yeah, easily about 5,000 kilocalories per day. Yeah, I do. Without the working out. Without the workout part. But yeah, I can do that. With my eyes closed. Again, so the other therapy here, can you suggest maybe steroids? You think steroids will help? Actually, there's no evidence. So according to somewhere here in your chapter, there's no evidence that steroids help. Let's talk about fluids. Can we give these patients fluids? Remember, they're NPO. IV fluids. Can we give them IV fluids?
With caution,
Why with caution?
because
Remember, how did this water end up in the lungs? Leaking. So therefore, if you give them IV fluids, where will that IV fluid go? If the capillaries in the alveoli are leaking, where are they gonna go? Into the alveoli. So will the IV fluids help? However, because they are sick and they're NPO, do they require IV fluids? So you understand how that, does that complicate the treatment even more? So that's why, again, so you still wonder why ARDS has a high mortality. Yes, because you're damned. The patient is damned if they don't receive fluids. They're also damned if you give them fluids. All right, you understand the complexity that we're dealing with here. Okay, there's really no magic bullet. There's no steroid that will stop this. We're at the mercy of the body. The body has to stop this self-destructive reaction. All right, because we can't tell the body to stop it. There's no drug to do that. If we did, then the mortality would be down to 0. Okay, so that's why we're happy COVID is gone, because otherwise we would still be dealing with ARDS. So the causes of death for COVID patients wasn't COVID. It's either ARDS or DIC. That's what they die from. So sepsis, because they go into sepsis, correct? And sepsis is the top cause of ARDS, because sepsis is indirect lung injury. Any questions on ARDS? That's it. What did Miss Cadet say? Cautiously. Cautiously. So a lot or conservative fluids? Liberal or conservative? Conservative fluid therapy. Okay, very, very controlled. Yes.
So for the only sign that I see
Uh-huh.
in the paragraph is like the fifth lung.
Again, okay, so let's go back here because you're looking for signs and symptoms. So how did we diagnose, you have no question on acute respiratory failure, right? You're okay with that?
Yeah.
All right. So with ARDS, since we said ARDS is acute respiratory failure as well,
So it's the same time and symptom.
same. However, unlike respiratory failure, wherein did they respond to oxygen?
Yeah.
Yes. These guys here with ARDS, do they respond to oxygen? No, they're unresponsive to, okay, right here. So they are unresponsive to oxygen therapy. Where is that? Right here, unresponsive. Why unresponsive?
Because they're leaking, so there's. no
Because
gas
the lungs are
They're wet.
wet, they're very wet. The lungs are filled with water, so of course they won't respond to oxygen. You give them gallons and gallons of oxygen. Is it gonna work? Not without a mechanical ventilator. So do you want to have ARDS?
No.
That's about it for ARDS. Like I said, we'll do the ventilation next week because this is long. Let's end with